Hey everyone, for today's video I'm going to be discussing the basics of TCC accession or tunneled cuffed catheter accession. The steps for using a temporary hemodialysis catheter are largely the same, but we're going to be focusing on permanent hemolines for now. Please note that these steps are largely based off the 2017 BC Renal Central Venous Catheter Guidelines, which I'll link to below, and I strongly encourage you to print off a copy to follow along. If you have any questions or note any errors in the video, please don't hesitate to reach out. I will be making some extra on-screen notes that I neglected to mention during my filming. Please incorporate these into your technique. So, first things first, you're going to start by gathering all the necessary equipment. This may vary slightly depending on which technique you're utilizing, but will largely consist of the items you see on the screen. You can organize your pack however it makes sense to you, but I tend to organize mine as seen, where one side is for accession and the other is for discontinuation of dialysis. Once your supplies are organized, you'll want to perform hand hygiene and don your PPE, which should, at minimum, be surgical gloves, a mask, and eye protection. Place the patient supine, as flat as they can comfortably tolerate. Doing so will help minimize the risk of air emboli while also preventing your blue pad and other supplies from slipping down. The patient should be masked, or at minimum turned away from the TCC site. Be sure you are using an appropriate cleanser, such as the ones listed on the screen. Please note that chlorhexidine alone is not currently listed as an approved cleanser by BC Renal. It is also important to note you should never leave your catheter ports unattended and open to air. Clamp the ports whenever not in use. So here I'm going to start by unwrapping the previous dressing. You can see, per our sticker, the line was previously capped using sodium citrate, and the capping volume for both the arterial and venous lumens is written. Upon removal of the outer dressing, it is apparent that the tegos are both securely attached and the clamps are closed. At this point, you should discard your gloves, perform hand hygiene, and don a new pair. Next, it's important to provide a thorough cleanse to the entirety of the exposed catheter, as it's been wrapped up for the last 48 hours or so. Typically, I'll start from the bottom of the catheter at points of connection and work my way upwards. This cleanse is done one lumen at a time, and it's important that once you have cleansed the exposed portions, you unclamp, move the clamp up or down, supporting the catheter as you do, as to not put any tension on the insertion, reclamp, and cleanse the newly exposed area. Now, per best practice, you want to use a new swab when switching between the two lumens, so I'm going to grab my new swab and repeat the process. Now, you don't have to hold the line like this, but this is just my technique. I'm going to set it down after when I have a clean working surface. Really just trying to get every surface that was covered underneath the dressing, including the clamp itself, and then again, unclamping. You can move these clamps up or down. I'm going to choose to move these up, reclamping, cleaning underneath that surface as well. So now that I've cleaned the lines, I want to put a nice clean working surface underneath them. So I'm going to use my clean, not sterile, blue pad and kind of tuck it under there. And then I am going to take my sterile 4x4 and just tuck that underneath. I like to keep the paper backing underneath it. You certainly don't have to. You can just use the gauze if that's preferable to you. I wouldn't normally be working directly over my surface here, but I'm just doing this so you can see it. So I'm going to pretend that I do need to change my tegos. The way that I typically do this, now you can just take this tego out of the packaging and connect it directly on there. But to save me a step, and so I'm not fumbling with anything, what I typically do is I will actually connect my 10 ml syringe directly to my tego so that they're ready to go to connect straight onto there. My rationale is that these are both sterile. I'm connecting a sterile tip to another sterile tip, so I'm not worried about contamination. So what I typically do is I'll actually open this backwards, so you just get a little edge here, and gently peel this open, being careful not to touch any of the sterile components. I'm going to take my 10 ml syringe and I'm just going to twist that directly onto there. So sterile to sterile. And then I've got it neatly contained within my packaging. You certainly don't have to do it that way. You can do it individually. It just means cleaning the tego again before you attach your 10 ml syringe. So we're going to change the tego. It doesn't matter which lumen you start with, whichever one makes sense to you. You always want to double, triple check that your clamp is activated. You never want to remove the Tego if your clamp is not on, because you pose a serious risk of air emboli. So clamp is activated. I've got my sterile 4x4 underneath. I've already cleaned. I'm getting a brand new approved cleanser here. I'm going to twist off the old Tego. These can be quite stiff, so sometimes you may need to grab some sterile gauze to kind of get a little bit extra friction to take that off. So I'm just going to remove and discard this. And then with my brand new cleanser, I'm going to perform a thorough hub scrub here, paying special attention to the bottom. Depending on which cleanser you're using, you need to ensure that you're giving adequate dry time. Once I've given sufficient dry time, and again, I wouldn't be working directly over top of this, I'm going to take my connected kit here. I use my pinky finger, and I'm just going to gently, again, being very careful not to potentially contaminate, remove the blue tip here. This just lure locks directly into here. Make sure it's on there good and firm. Now I've changed out the Tego, but you may be aware that this is not yet primed. So there is about 0.1 volume in here that if I just push something in would potentially allow a small amount of air into the lines. So I'm actually going to remove the capping solution now, which will in essence prime that. I'm going to unclamp. Unfortunately, I don't have any liquid in here, but the general idea is based on the volume of the capping solution, you're going to remove that volume plus a little extra. So typically 3 to 5 mils. So you're going to remove that volume, clamp in between, disconnect, and now this, which would be full of blood and capping solution, is discarded. You would not use this to get a glucometer because it's going to be a dilute sample and it's not going to be accurate. So because I've just switched out the Tego, I don't want to use that same swab because I've scrubbed it. It's probably got a bit of blood on it and some other debris. So you're going to get a brand new cleanser. And now you're going to give a good hub scrub again. Whenever you're connecting anything to the Tego, you need to remember to do a thorough hub scrub. So anytime you're disconnecting and reconnecting, you scrub in between. So you certainly don't have to do this, but I always like to have the cleanser close by. So I'll give a really thorough hub scrub, and then using this finger, I'll just kind of pinch the cleanser underneath. So it's not actually directly in contact because I want to give it time to dry, but it's very close so that at my next swab, it's right there for me to grab again. So the whole time I'll hold it like this. If you do happen to let it go, that's fine. You just need to use your cleanser again, because if this touches something else, you're going to need to cleanse it again. So thorough cleanse. I keep mine under there, give it adequate drying time, which will change depending on which solution you're using. So once I've provided enough time for that to thoroughly dry, I'm going to take my new 10 ml syringe, lure lock it on, and then I'm going to unclamp my clamp. So here we're doing a patency assessment. What I'm going to be doing is I'm actually going to be aspirating and then gently reinstilling. And we're going to do this 2 to 3 times. What would be happening here, of course, is this syringe would be filling with blood. And what I'm doing is I'm trying to see how easy is it for me to aspirate. Are there any stops and starts? Am I attempting to aspirate and it's not giving me any blood back? And then what could be the potential cause here? Do I think I have a faulty Tego? Is it possible that there's some clotting occurring here, fibrin sheath? And comparing the two, so it allows you to determine which lumen would be ideal as your arterial for hemodialysis. So again, 2 to 3, just to give you an idea how this lumen is performing. And obviously when you're aspirating and instilling, if there are any air bubbles in the syringe, be very careful not to reinstill them. So if there's a small amount at the end, I just wouldn't fully depress the plunger. If the patient does need a gluc, you can certainly save yourself a small volume of blood here and just disconnect it and set it to the side afterwards. So I've done my patency assessment. I'm gonna reclamp, disconnect this, and set it off to the side. So now this lumen would be full of the patient's blood, so I certainly want to get that out of there as soon as possible to prevent any clotting or occlusions in the catheter. Anytime I'm connecting something new to this lumen, I want to give it a thorough cleanse. You can reuse the same swab, but if it is soiled or if it dries out, certainly get a brand new one. Really thorough scrub here, paying attention to the bottom, allowing adequate dry time to thoroughly disinfect that lumen. Next, you're going to come back with a pre-filled syringe of normal saline. You're going to need 20 mils per lumen. I've already expelled the air from this one, so it's ready to go for me. I'm going to use my pinky. If you don't have that dexterity yet, you can certainly set this down and twist it off. But remember, if this touches anything, you're going to need to clean it again. I'm just going to disconnect this and lure lock it in place. I'm going to unclamp. Now, unlike the smooth aspiration for my patency check and installation, this is actually going to be a pulsatile flush, so I want it to be a little bit aggressive to clear any of the blood out of here. So that's flush, flush, flush. We're going to clamp, discard, and repeat the process again with a brand new 10 ml prefill. Again, pretending that I've given thorough dry time, just so you're not waiting around for me. Unclamp, flush, 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 clamp. Now this lumen is ready to go. This one I still need to access and do the Tego change, but this one is cleared of blood. I'm not worried about it clotting. I'm going to set it down. I like to keep the disinfectant and I put it directly underneath it so it keeps it in place. Again, if it dries out or if you lose it, just grab a new one, no worries. I leave the 10 ml pre-filled on here as well because it's a really good visual for me, so I'm very clear on which one I have got ready to go, because normally, of course, these two will be clear. So now we're going to just repeat that exact same process, but here on the venous lumen. And again, doesn't matter which one you start with, but we're going to move on to this guy. So I've got my new swab ready to go. I do have to change the Tego, double, triple checking that my clamp is engaged, so there's no risk of air emboli to the patient. I'm going to twist this off and discard, give this a really thorough cleanse. When you're doing this, I really strongly encourage you to have your supplies ready, because you don't want to let go and then potentially have this touch something or become contaminated. So you really want your supplies on hand, close by, so that you can maintain a good grip on this, allow it to dry, and then put your Tego directly on. If you're not doing the method that I was doing before, you're going to take your Tego out of the packaging just like this, and then you can use, again, some of your other fingers to take that off and lure lock it on after adequate dry time. My clamp is fully engaged throughout that whole process, and this swab is now garbage because I've used it to do a scrub on the exposed lumen here, and likely it's got some blood or crusties on it, so that's just going to get thrown away. Okay, so again, bearing in mind here that I've attached a Tego without priming it with saline or anything else, I don't want to flush anything in because a small volume of air will be instilled into the patient. So I've attached this right off the start. I have a brand new swab, and I'm going to use this to do a thorough hub scrub. I know it's coming out of sterile packaging, but I was touching it while I was getting it ready. Thorough dry time, making sure that your swab is not in contact with the hub. I'm going to take a brand new empty 10 ml syringe, lure lock that in place. These can get really easily cross-threaded if you're not careful with it, so it's important to do firm inward pressure and then twist. If you notice that it is cross-threaded, just back it off, push in, and then re-thread it as best you can. There should not be a significant gap here between the 10 ml syringe and the Tego. If there is a gap, it's either threaded incorrectly or it's not securely on, so make sure you're trying to give it an extra twist or taking it back and then trying again. 10 mils on, I'm going to take my clamp off. We're just removing our capping solution, so that's where we're going to take the 3 to 5 mils. You wouldn't see these bubbles. I'm just using a fake setup here, so of course it's going to be a little odd. So you would normally get blood red liquid that's semi-translucent with the capping solution, and this is to be discarded. So I'm going to clamp before disconnecting, discard this solution. It is not useful for glucometer or anything else. And then again, give it a good thorough scrub before applying another syringe. And it is helpful to pre-open your packages so you can grab them a little easy. I'm going to set this down for a second to kind of show you. I don't really recommend taking them completely off. It's a higher risk for contamination, but if you have them pre-opened, then with one hand you can essentially take them out of the packaging without risking contaminating it. I'm going to twist this on and do my patency assessment. So I'm going to unclamp. I'm going to take my 10 mils out and then gently reinstill, and then 10 mils out again, gently reinstill. This syringe should be filling with the patient's blood, and I shouldn't expect any significant resistance. Of course, with catheters that have been in use for quite a while, it's not unusual for one lumen to work better than the other, and this may alternate depending on what's been going on with the patient. So I'm making a mental note comparing my venous and my arterial to determine which one I would like to use to pull blood from. The lumen that it is easier for you to aspirate and flush back into is typically the lumen you want as your arterial. You can utilize either of these lumens as your arterial. They're just color-coded to identify them, but I can use this venous lumen as my arterial and this arterial lumen as my venous return. Doesn't matter, you can switch them around. So again, just doing 3 aspirate and gentle reinstallations. This is not pulsatile, it's just a smooth action aspiration and gentle reinstallation. I'm going to reclamp. If this patient needed a gluc, I could save a bit of blood from here. And this is the best time to draw blood work as well, as you've aspirated and reinstilled fresh blood 3 different times here. This is still full of the patient's blood, so I want to repeat that 20 ml pulsatile flush. So again, I've got my saline ready to go. I've taken the air out of it. I don't recommend doing this far in advance of your patient's arrival. You can do this when you see the whites of their eyes when they're at the station with you, but I don't want breaks in sterility well in advance to the patient actually arriving, because then they're sitting out for a prolonged period. Thorough cleanse, adequate dry time, unclamp, flush, 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 reclamp, scrub, lure lock, unclamp, flush, 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 reclamp, and now both lumens are ready to go to be hooked up for hemodialysis. Now, if at any point in this procedure you noticed on installation or aspiration, one of the lumens in particular was really sticky, so you were having resistance either pulling blood out or reinstilling blood, the first thing I would suggest addressing is the tego. Even if you just changed the tego, unfortunately these devices are prone to failure, so based on my initial assessment, I would determine which lumen I wanted to utilize as my arterial. For the purpose of the video today, I'm going to indicate that my venous lumen here, I actually had a bit of an easier time aspirating and reinstilling, so I'd like to use this guy as my arterial. It's going to be easier to pull blood from this lumen that is less sticky, and then you can usually get away with instilling blood into a lumen that is slightly stickier. Now, this doesn't mean it has to maintain this for the entire hemodialysis. You can swap this as needed after initiating dialysis. So typically I allow my students to utilize the same cleanser if the swab is not soiled and it is still moist. Of course, depending on how long it takes you to do this, if it has dried out, you're going to grab a brand new swab for this final hub scrub. But if you're fairly quick about it and these are still moist and not soiled, certainly feel free to use them again. I'm going to use my venous as my arterial in this case. So it's ready to go. I'm going to disconnect my 10 ml saline. I'm going to give one final thorough hub scrub here. So I'm going to grab my arterial from the machine and hook it up to my venous lumen. I'm just going to use my pinky finger here to kind of twist this guy off and then push in and lure lock. This is the point that I often see students accidentally cross thread and have significant gaps in between their lines and their tegos. So this is where, again, if I have that significant gap, I'm going to twist it off a bit, push in firmly, and attempt to tighten it all the way up. I shouldn't see any significant gaps in between the tego and the lines here. Now that I've connected these clamps on the machine can stay open, but now that I've connected these, I am going to unclamp my venous lumen here so that it is ready to go. I'm now going to repeat the exact same process for my arterial lumen here, which in this case, because we're reversing the lines, will be used as my venous as my return. I'm going to take this guy off and discard my swab, pinky finger, pushing in firmly and twisting. I'm going to undo my clamp, and these guys are ready to go. Now, before I let these go, I typically would ask my patient to either hold them or I'm just going to immediately secure them somewhere safe so that if they do fall, they don't pull on the patient's line. I want to make sure that they've got a good grip on them or that I've secured them either to the patient with a blue clamp or something else. Now, once my lines are attached and I've initiated my treatment and I understand that both of these are functioning well, I don't need any other interventions. My general practice, just to protect these, as long as my 4x4 isn't soiled, if it is soiled, I'll swap it out for a new one, is I like to take my 4x4 and cover my points of connection here, my tegos. I gently cover them, and then I'm just going to clamp a blue clamp in place there, something like that. So it kind of protects those points of connection from any contaminants. And then depending on patient preference, you can certainly pull this out and leave it just up against their skin, or leave the blue pad around and wrap it. All right, so we're going to say we've reached close to the end of dialysis. I want to ensure that I have the appropriate capping solution drawn up, so I'm going to consult the physician's orders and what we have written on our hemo log for the lumen length. However, when in doubt, on any standard TCC, you should be able to look at the line itself, and it should have printed clearly on it the actual lumen length, which will be in centimeters, which is equivalent to our milliliters for capping solution. So if you guys remember at the beginning of the video, we were utilizing sodium citrate 4% solution for this person's capping. On the lumens themselves, we'll say we see 1.6, and per our policy, it is lumen length plus 0.2 for sodium citrate, so 1.6 makes for 1.8 for the arterial and the venous. Most catheters that I've encountered have the same arterial and venous capping volumes. However, you do want to be careful, as there are catheters that will have different volumes for arterial and venous, and in that case, you need to be very certain about which one you need to inject the correct volume into. I've got my gloves on right now, so if I'm handling my pen, I'm going to be getting new gloves for this, but basically I'm ensuring that I have the appropriate capping solution with me, and then I'm going to ensure that I have the correct volume ready to go in these guys for the end of treatment. So we're going to say that treatment has concluded, so we're going to prepare the patient to be taken off. I've had this in place for the duration of the run, which has kept my lines nice and safe, but it's been sitting there for several hours, so I want to provide myself with the cleanest working space I possibly can here. So typically what I'll do is discard this, bring a fresh new blue pad right underneath there, and then again, take a brand new 4x4 and place it under my lines. So we are going to be disconnecting the patient, so the blood is still circulating at this point. So on our machines, we're going to stop treatment and prepare for rinse back. So in order to effectively rinse back the patient, we're always going to start with the arterial line, because that's what we're going to hook to our saline bag to allow the saline to push the patient's blood back to them through the venous line into them. I'm going to clamp this. You can also clamp this side as well. Disconnect here, and then I'm going to connect my arterial line to my saline bag on the machine to allow for rinse back to initiate. You don't have to hang on to this line, because we're going to be cleaning and flushing that line in just a moment's time. I'm going to give a really good scrub here, taking one of my fresh pre-filled 10 ml saline syringes, and we're going to do another pulsatile flush for 20 mils here. Connect, unclamp, flush, 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 reclamp, cleanse, flush, 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 clamp, scrub, air dry, and now I'm prepared to instill my capping solution. So the technique here is going to be a little different. I've got my capping solution ready to go. So with this one, we want to try and create positive pressure in the lumen here. So what we're actually going to do is gently, not pulsatile, we're going to gently instill all of this liquid, which I've pre-measured. And as the last of the liquid enters, as the plunger fully depresses, I want to clamp this line at the same time. So it can be a little tricky when you're first learning. So you're going to unclamp that, but you're going to gently instill this. And then as the plunger fully depresses, so there, I clamp. So then I'm creating positive pressure within the line. Disconnect that and give it one final cleanse, because it's going to be going away after this for the next 48 hours or so. So we're going to say that as we've been doing this, our blood has been rinsing back. So typically at 100 ml pump speed, it'll take around 3 minutes to rinse the patient's blood fully back to them. We're going to say that the blood has rinsed fully back and that this is kind of a translucent or transparent red, kind of like cranberry juice. So I'm going to clamp this line off here, clamp this line here, and prepare to do the exact same thing with this lumen. Now I'm finished with this lumen, so I'm not as concerned about the sterility here, but still I want to take care of this and connect it to the machine so that in the event that I did need it, it's available. But really, once we've hit disconnect, we should be done. I'm keeping track of which one I've done, but it should be apparent because this lumen itself should have that translucent pink, and this should be clear with my capping solution. I'm going to connect that to the machine, and then I'm going to come back over to this guy and do my good hub scrub, unclamp, flush, 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 clamp, scrub, unclamp, flush, 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 reclamp, cleanse, unclamp, and then just like we did before, so we're going to gently instill, and as the plunger fully depresses, clamp. So then they've got all the capping solution. I've created that positive pressure. It's one final wipe. All right, so these guys are both clamped. You want to make double, triple sure before you put the catheter away that these guys are both securely clamped. If the tagos are on, they're going to prevent anything from entering or coming out of the catheter without something luer locked into it, but these are your backups. So it's really important that you ensure that these are appropriately clamped. We're going to wrap the catheter. So this is just the way I like to do it. These 4x4s that we have come in packs of 2. I find one piece that I can peel open so that it's connected right here. So I basically rest it in my palm like that. And then what I'm gonna do is lift the whole catheter, and then I place the tago tips basically right there where it's connected, and then I fold it over top. And then what I'm gonna do is basically make a little burrito. I'm gonna fold one side in fairly tight, fold the other side in fairly tight, and then I've got it wrapped nicely. Then we're going to take our appropriate capping solution label here, and I'm going to peel that edge off, and then I'm going to wrap it together. Place it on there, and then put just a little bit of tension, so I'm creating a nice firm little burrito here, and then continue to wrap around it there. Usually I don't use this same gauze because it typically has a bit of blood. It's kind of wet from the disinfectants. I want to give them a nice clean dry one because it's going to be on there for some time. So the nice thing about this is we have the wrap on here so that in an emergency scenario, if anyone needed to use it, they can see that it has sodium citrate in it and how much to remove before they could actually use the line. So I've got it wrapped with this, and then we use our little socks here. You'll get comfortable with what length you actually want these to be. Usually longer is better than short. I'm gonna kind of open up a little bundle here with my hand, put it over. Create a little tension here, and then put a twist or two into this. And then I'm going to open up the other end here, and then I'm just going to take this and wrap it back over top so that it covers the whole thing. And then you have this nice, neat little package. You can send your patient home with this. So then we're just going to take this out, and the patient is done and ready to go.